So for the last 8 minutes, Paul had actually asked me to talk about the science of Sapien. And when trying to figure out how to address this lecture, I figured I was going to talk a little bit about how we started and where we are now. So everything started on April 16th of 2002 when the first catheter valve replacement was performed successfully. And since then, for the last 16 years, we've actually been in part of the revolution of transcatheter valve replacement. And what we've seen in 16 years related to the balloon expandable Sapien family of valves is that we have more than 7,300 patients treated in the United States in a research trial. We have more than 95 publications and others that are in press. And we have more than 100,000 patients treated commercially. So all in all, there is a fair amount of data that we've actually been able to extrapolate from the history and hopefully try to predict what's going to happen in the near future. So it all started with the Cribier valve that then clearly transformed into the Sapien valve for the Partner 1 set of trials, then the Sapien XT for the Partner 2A, 2B trial, and then finally the Sapien 3 valve, which was placed in the intermediate risk category and in the low risk trial. And each step of engineering changes has actually led to the outcomes that we previously heard from Dr. Brown. And the first thing that we changed was the balloon. The first TAVR in a balloon expandable valve was actually mounted on a balloon that was non-proprietary. It was crimped right then and there without any evidence of markings or things of that nature. And with that, there was a lot of variability in the positioning and in the deployment. So the first big step, since we do not have the ability to reposition the valve, was to make sure we have a very exact and precise mechanism that is easily reproducible in trying to deploy these valves. And as a result, Edwards came back with a balloon that was volumetrically sized, and the vents were actually changed in their position. And as a result, the balloon was able to expand more predictably. And as a result, you were able to have appropriate inflation pattern and a very appropriate sizing, which would then lead to less complications. The next thing that changed was the delivery system. Once again, we started with a stiff catheter that had a small amount of angulation to it, but no nose cone, which made it very difficult to traverse the aortic valve. And then from the different modifications, from the Retroflex, Retroflex 3, NovaFlex, to finally the Commander system that we all currently use and are actually very pampered with, we're now able to treat and travel through pretty much any vessel tortuosity, angulation across the aortic, the ascending aorta, and difficult aortic arches. All of this while maintaining the coaxiality of the valve, which then would lead to an increase in the number of the patients that we can treat and treat safely. In addition, hopefully by decreasing the amount of scraping that we get within the aortic arch, and as the change in the diameter of the catheters happen, we basically will decrease the amount of strokes as we have seen before. So all in all, these technological advancements have actually allowed us to travel across the aortic arch, cross the valve more safely, and maintain coaxiality to have a predictable deployment. The next big step was the sheath. We started with a very stiff, hard sheath that then transitioned over to the expandable sheath that we're all familiar with. And for all of us, for all the fellows and for all the younger practitioners who are only familiar with the expandable sheaths, it's a pretty big difference. You'll see there's actually something coming down in the pipeline that is even more exciting than our E-Sheath 2 that we currently use. And what started as a 24 French system, which now finishes at a 14 French system, is actually quite remarkable, as you can remember. However, the biggest iterations also happened within the valve per se. We went from a balloon expandable valve that was made out of stainless steel to one valve that was made out of cobalt chromium. It appeared to be somewhat smaller with wider cells. This actually allowed to have the same amount of radial strength while maintaining the appropriate circularity of the valve. In addition, the leaflets changed in order to make sure that they would potentially enhance durability and improve their form. And then from there, we moved on to the Sapien 3 system, where once again, there was one more big iteration. There was now different cells designs. There's both large cells in the top and bottom cells and smaller cells in the bottom that basically allow for a very predictable deployment and non-movable or non-movement of the valve. As a result, you have appropriate radial strength in addition to appropriate coronary access if you ever need to address it in the future as we begin to tackle lower risk patients. And then the idea of the outer skirt became very useful in order to minimize the amount of perivalvular insufficiency, which was thought to be one of the largest Achilles heels in the catheter valve procedures. As you can see here, when we deployed a Sapien XT valve, there was very little predictability on how the balloon was going to expand. Well, if you can see on the other side how you basically expand a Sapien 3 valve where there's relatively no movement whatsoever as the valve is deployed. And all of this happened because of the combination of the delivery system, the change in the balloon, and the change in the cell design. And as a result, now we have a highly predictable platform that avoids us from having valve regret. Now, from a durability perspective, we've seen the data from Dr. Mack et al. From the partner trial, where we have documented durability of more than 5 years, both with an appropriate hemodynamic profile and an appropriate valve area. The other thing that we've seen within all of the partner family of trials is that in the extreme risk and the inoperable patients, transcatheter valve replacement saves lives, prevents hospitalizations, and prevents heart failure. And as a result, it's better than medical therapy. In the high-risk individuals, they're non-inferior to surgical valve replacement in the primary endpoint of death and stroke, with a potential slight advantage in the lower-risk individuals, as you can see further. And finally, in the intermediate risk patients, you'll see that there's, once again, non-inferiority from a perspective of SAVR versus TAVR. However, in the transfemoral cohort, there is definitely suggestion that there could be a survival advantage from the transcatheter valve replacement. All in all, you can see that the vascular complications are not necessarily insignificant, but they're much lower today than what they were when we started. And the pacemaker rate is still numerically larger than SAVR, which is something we always have to keep in the back of our minds. When you see the data from, that was published by Vino from the Sapien 3 intermediate risk, you once again can clearly see that there's a firm survival difference or an avoidance of mortality within the TAVR valves as compared to the SAVR valves, which is something that is very remarkable. And as you can see here in a slide that was previously shown as well, you'll see that the mortality of the patients has decreased dramatically as we begin to tackle lower risk patients, but also in the same patient subset that were considered previously inoperable or high risk. And in all honesty, in order to maintain a 30-day mortality of 2% or of 1.1%, that leads to all of what we've actually learned from the previous experiences on patient selection and the procedural refinement. Vascular complications have dropped dramatically. As you'll see, we started with 16% with a 24 French delivery system, and now with the data that was presented at EuroPCR by Dr. Touchou, you could see that even in the commercial setting with the TVT registry, for all comers, there's a 4% rate of vascular complications, which is once again very remarkable considering this started in a very sub-selected group of institutions and now is pretty much disseminated throughout the United States. The stroke rate continues to decline, which is questionable. Definitely the clinical stroke rate is lower. However, the neurological or the radiological stroke rate is very different. And I think here's where we're going to see the majority of the advances or the changes that will happen over the next 2 to 3 years. We've learned that conduction abnormalities are not necessarily inconsequential. However, in the high-risk individuals, it appears that they're not as dramatic as they are in intermediate-risk patients, particularly because of their overall survival. However, we'll see if this still continues to become an issue in the lower-risk patients as we continue to evaluate them in follow-up. The versatility of the valve also is very helpful. As you can see, we can treat now native aortic valve stenosis, degenerative bioprosthetic valves quite safely, pulmonic prosthesis also quite safely, and now the mitral prosthesis, all within the same valve. So the Sapien balloon expandable family of valves actually allows you to have that versatility, which is something that is pretty much unequal to any other valve. But where do we go from now? So partner 3 is closed, so the low-risk individuals are now officially or can be treated with transcatheter valve replacement. They'll continue to be followed up, but the continued access registry that will enroll 2,000 patients is up and running. There's an underrepresented population registry, which is important. The bicuspid registry is now closed and is in follow-up, at least with these 75 patients. And then the aortic valve-in-valve for low risk and intermediate risk, and the mitral valve-in-valve registry for intermediate risk patients is actually up and running. But importantly, we need to make sure that we know what happens to patients who develop a failed bioprosthetic valve. What happens to the TAVR that's failed? We've all treated them, but we've not necessarily systematically analyzed them. So this is a plea for patients to be enrolled in the valve-in-valve registry for a failed bioprosthetic valve, a failed TAVR valve if possible. Early TAVR is coming, so we're trying to see if patients should be treated if they have asymptomatic severe aortic stenosis with a long-term follow-up, and whether or not there's a biomarker predictability of who would benefit more from this procedure if this becomes appropriate. TAVR Unload is also very exciting. It treats patients with moderate AS and LV dysfunction. This also will change the paradigm on how we approach patients with heart failure if this happens to be a positive trial. So more to come on this as well. And finally, this is a slide from Raj Makar that I borrowed, but he presented matched data on on TAVR and bicuspid valves, and they got matched to patients with a tri-leaflet valve. And notice that there's the rates of aortic insufficiency appear to be very similar, which once again can lead to better selection and better availability for this type of technology in this patient subset that has not been treated so far as diligently as what we have with a tri-leaflet valve. As far as device innovation goes, the Axella sheath is the next generation sheath that we'll have. So E-sheath will be out, Axella will be in. We know that this is a seamless expandable sheath, which has an elastic layer that actively contracts after it expands when the valve goes through. So that's very exciting. And it appears that all prosthetics will now fit through the 14 French size as opposed to needing a 16 French sheath. The Ultra delivery system is a next generation commander system in which you won't necessarily have to lock or unlock the device, but more importantly, the valve will actually be mounted on the balloon when you start, which then will make the procedure a little more seamless and potentially faster. And then in addition to that, there's a responsive articulation that will allow you to traverse through multiple tortuosities. And finally, Sapien Ultra, which actually has the same stent design as was previously seen, but you'll see that there is actually a longer skirt that now which is 40% taller, and it's textured in order to help facilitate the coverage of paravalvular insufficiency. So we've gone from patients who have surgical risk from high, and intermediate, and potentially low risk. But what I would potentially offer to you is the idea that surgical risk is not equal to procedural risk. And we'll definitely want to make sure that we evaluate patients' anatomy and then decide if TAVR is the way to go, if SAVR is the way to go, or how to address this. So let's forget about the STS 1 through 10 or 1 through 15, and hopefully try to focus on anatomically which are the patients who would likely benefit the most from one or the other procedures. These are the characteristics of the Sapien valve, and I can see that with the data that we have so far, that we've accumulated, we pretty much have answered and have generated a device that is simple to use, it's predictable, is versatile, has very low stroke rate, hopefully a lower pacemaker rate, and has significant areas to decrease vascular complications. Thank you.